Well, I tried to put in this camera.
All right, good morning, everyone. Welcome to Pediatric Grand Rounds. Thank you for joining us. We are in the beautiful Mill Mountain Conference Room. I do see some snacks at the back of the room. If you're anywhere nearby, please come and join us in person. Today's speaker is Dr. Jennifer Wells. Dr. Wells is Director of the Women's Mental Health Division of the Department of Psychiatry and Behavioral Medicine for Carilion Clinic in Roanoke, Virginia. She is board certified in psychiatry and addiction medicine and serves as an assistant professor for BTC-SOM. She actively teaches medical students and residents from a variety of disciplines, and her role is both an inpatient psychiatry attending and outpatient clinician specializing in reproductive psychiatry. Her focus for the last 10 years has been on treating mental health and addiction disorders in pregnant and parenting women. She currently runs an MAT program with about 75 pregnant and parenting women as part of the Carilion Clinic's OBAC program. She graduated Phi Beta Kappa from UC Davis as an undergraduate and matriculated at Georgetown University School of Medicine. She then trained as an OB at UCSF. After completing her OB residency, she left medicine to focus on other endeavors and eventually returned to complete an additional psychiatry residency at Virginia Tech Carilion. Her zeal for treating mental health and addiction issues in women was born from both her training and personal experiences, and continues to drive her passion for treating this challenging population. In her spare time, she enjoys hiking, traveling, lots of adventures, scuba and safari adventures, and spending time with her 2 dogs. Please join me in welcoming Dr. Jennifer Wells. In May, and as many of you may know, it is Mental Health Awareness Month, and this is one of a series of activities that she's been involved with as part of the Mental Health Collaborative at Carilion that ties in psychiatry, pediatrics, OB, and other community health mental health. Please join me in welcoming Dr. Jennifer Wells.
Hi, good morning. Thank you guys so much. Is this too loud? I have a big voice. Okay, I'll try to modulate it as I can and step out from behind the slides as I can. This is a new slide deck. I don't often talk to pediatricians, so I'm sort of grateful to see you and meet you, and I hope this targets some of the things that you guys can do to help me treat this population of people. I did study OBGYN first and then did a psychiatry residency, so you can see where the overlap comes in on perinatal mental health. I'm sort of uniquely suited. Having been in the OBGYN realm, I feel comfortable with obstetric and gynecologic conditions, and then moving into psychiatry, I obviously feel comfortable there, so it's sort of a natural match for me to do this. There we go. As Vidya said, May is Mental Health Awareness Month. For people who do what I do, I like to think of it as Maternal Mental Health Awareness Month. And there's a lot of stuff that goes on around the globe. The first Wednesday in every May is World Maternal Mental Health Day. You can see that symbol. That's a symbol of Maternal Mental Health Day around the world. There are activities that go on around the globe. You can look it up. Postpartum Support International is probably the entity that has the most investment in what happens. So if it's something you're looking to be part of, that's where you should look. We did have a number of activities as part of the Women's Mental Health Collaborative, which I'll talk a little bit more about later here at Carilion. So reaching out to different departments to let people know that what we do, that we are interested in women's mental health, that we realize it has to be a collaboration with all of our departments. That's pretty hard, I've found, in big medical institutions to reach across departments. Injecting sort of psychiatry into different silos is a hard thing to do, but that's why I'm here. So let's talk about some of the things we want to get work done on today. So discussing the importance of perinatal mental health to women, children, families. Understand your guys' role in supporting the parent-infant dyad. Delineate some of the basic principles behind psychotropic treatment in pregnancy to sort of demystify it and make it like, oh no, this is really regular medicine, everyday medicine now. And identify and use PMADS pharmacotherapy resources to support better this population. So it's sort of, I'm here to say, like, we have a problem. I have a problem. I need your help. Psychiatry needs your help. We need OBGYN, we need family and community medicine, we need pediatrics to treat this population. Sometimes you're the first people to see a depressed mother postpartum, or a depressed mother pregnant, bringing in her older child to see you guys. You might be the first line, and so I want to give you some tools to help identify and get those people to treatment wherever that may be. What you've noticed already in just the first couple slides, we have a lot of terms in maternal mental health, and some of it is trying to move, I think this is a newer field, move towards more person-centered language, which is sort of something we talk a lot about in psychiatry. You guys probably do. Sometimes male and female don't work any longer, right? Maternal suggests female. That isn't always what a parent looks like these days. So there's a lot of different terms. I just outlined a few. Perinatal suggests 2-year time frame. Conception to the child's first birthday. Antenatal or prenatal are the same during pregnancy. Postpartum or postnatal, first year following pregnancy. Some people call it the 4th trimester. That's actually a trademarked term, and they don't love it when you use it outside of their trademark. Maternal mental health or illness is the same as perinatal mental health or illness. We talk about maternal mental health disorders. MMHD is the same as PMADS, or perinatal mood and anxiety disorders. That's what I use most commonly. I think it brings a little bit of heightened awareness that anxiety is a big problem. Postpartum depression gets all the press, right? That's what we got postpartum depression. If you're someone who works in my field, you see postpartum anxiety quite a bit more, or perinatal anxiety. Moving through a pregnancy, if it's your first, even I think sometimes if it's your 5th, it is anxiety provoking to be responsible for a new human being. There are many, many stresses that go along with being pregnant, having a baby, raising a child. It is not uncommon to have anxiety. What we need to figure out is it clinically significant, and then how do we treat that? So perinatal depression is the same as postpartum depression. Like, postpartum depression became this umbrella term for every mental health disorder that happened in the postpartum period. And I sort of want to move us away towards identifying what the disorder is and giving it a name. Perinatal anxiety is PPA, and more frequently we're seeing that fathers are coming into the picture, right? They're not immune. Anyone who's actually part of the birth experience, meaning part of conception, close with the person who is carrying the baby, into the delivery experience, into the postpartum period, is subject to have a mental health disorder. So you can see where maternal mental health disorder doesn't always fit. I'll focus mostly on the person having the baby, but let's try to keep in mind that fathers and other partners do suffer as well, and that can be an important component because it's additive, right? If you have a mom that's depressed and then you have a father that's depressed, that's a lot for a child, right? You're sort of moving towards an adverse childhood experience when you have dual parents that are depressed. So let's start with the scope of the problem. First, I said we have a problem. I have a problem. The problem is that maternal mortality in the U.S. continues to rise. You can see that black line at the top. That's us. All the other lines below, that's every other well-developed country in the world. We sit markedly above, and if you look to the right on the green, that's us, standing tall and not so proud, as showing U.S. maternal mortality rates exceeding anything that is happening in other high-income countries. And you'll notice the racial disparity. That last green column is the number of Black women who are experiencing a mortality rate far higher than the same age match controls in white women. So let's look at CDC pregnancy-related deaths. So the U.S., we just saw, has the highest maternal mortality ratio among wealthy countries, even when data is limited to white women. So that green stack first in was white women. The next stack on the previous side was Black women. We know that more than 80%, 84% to be exact, of pregnancy-related deaths were preventable, according to the 2017 to 2019 data from an MMRC. So an MMRC is a multidisciplinary review committee. It stands for Maternal Mortality Review Committee, and they perform a comprehensive review of deaths among individuals during and up to a year after pregnancy. When we look at the timing of those deaths, 22 occurred during pregnancy, 25 on the day of delivery or within the first week, and 53 occurred between 7 days and 1 year after the pregnancy. And why do we care about that? Because that's the time period for me to intervene. That's the time period for you to intervene. That's when you are seeing these people come into your office. And we know that we're going to see down the line that of those 53%, that is largely comprised of mental health conditions. So maternal mental health conditions, including suicide, overdose, poisoning related to substance use disorders, account for 23% of all CDC pregnancy-related deaths and are the leading cause of pregnancy-related death. Mental health conditions, leading cause. We have a problem. In 2021, 1,205 women died of maternal causes in the United States. That's increased from 861 in 2020 and 754 in 2019. So it probably isn't a far stretch to say that COVID had quite an impact on isolation, increasing depression symptoms and anxiety, and a lot of women giving birth, right? The entire framework upon which most family systems are built, which is community, support, togetherness, it takes a village, was deconstructed as part of COVID, and we're still seeing the results come through. If you're someone who likes schematics, on the left, I just want to highlight that the 52% in the postpartum maternal deaths, and you'll notice on the right, as we look towards the right of the right-handed graph, that the further we get out from delivery, the more maternal health conditions are responsible for pregnancy-related maternal deaths. And there are ethnic, racial disparities in pregnancy-related deaths, just as we saw before that U.S. Black women, that green stack on the far right was very high. Data tells us that there is significantly higher pregnancy-related mortality ratios among Black and American Indian and Alaskan Native women. And those gaps continue to the present time. They continue across our nation. Even if you go to states that have lower mortality ratios, we still see the racial disparity holding steady. Black women and American Indian, Alaskan Native women are dying more. It is true as we age. The older you are, the worse your mortality ratio. And it doesn't change based on your education level. So Black women with a college degree are dying at far larger rates than white women with the same educational level. It's distressing. And if we look just quickly in our state of Virginia here, you can see that we're tagging along right with the state's average, and we even sit a little bit higher, right? Maternal mortality, 50.1, higher than the U.S. average of 32.9, and same with the racial disparities, straight through Virginia as well. So, how does maternal mental health or perinatal mental health, see, I even have a problem switching terms, figure into this? Let's look at some basic stats. And I don't know how many of you guys are familiar with it. Do you hear it a lot? Do you guys hear about this a lot? Oh, good. I see some head shaking, so that's good. 1 in 5 women, on average, suffer from a perinatal mental health disorder or a perinatal mood and anxiety disorder. Up to 50%, 1 in 2 of BIPOC women, women living in poverty and sexual and gender minorities, will suffer from a PMAD. Women in their childbearing years account for the largest group with depression in the United States. So those are the people that I see and the people that you see. Suicide and overdose are the leading cause of death postpartum. So again, like we had said earlier, we know that pregnancy-related deaths are increasing. The majority of deaths occur in the postpartum period, and then mental health conditions play a greater role in those deaths as we move out postpartum. So you're seeing that suicide and overdose are the leading cause of death. Just as an additional statistic, there's about 400 million births in the U.S. each year, so that's 800,000 women affected. 1 in 5 of those, right, that's a lot, and can't remember what I was going to say. Roughly 1 in 5 of those women are not asked about depression during their prenatal visits, despite universal screening being recommended. We're not good at screening. None of us are, across the board. Psychiatry, we're not good at it. Obstetrics and gynecology, they're not good at it. I actually don't know the PEDS numbers. Are you guys good at it? Sometimes. All right, I'm getting a shady.
It varies.
I'm getting a shady look down the hall, so I'm gonna say you're probably not that good at it either. And we know that 75% of women, and that's like a generous number. Lots of data will quote 85% of women who experience a PMADS go untreated. Untreated. Not even touched. And we're talking about 1,200 women dying a year. So if you're someone who likes schematics, there's it in picture form for you. The thing I like, see, it used to be more than 600,000 women. This was done in 2020, I think. We're now at 800,000. 200,000 number jump. Part of that is the birth rate, and part of that is also COVID. And also, I think I like on the bottom 3 blocks in that anxiety and depression have risen 37% in teen girls. So these are your people. And we know if anxiety increases in teens, PMADS increases as they become young women, young adults, pregnant women, mothers. So we're going to watch this crisis sort of continue. Let's talk a little bit about suicide. Nobody likes it. It's a complicated set of symptoms that leads to suicidality and suicidal ideation, and I think a lot of times we're not so good at screening for mental health disorders because we're terrified if we get a yes. And what are we going to do? How do we manage it? Where do we send people? So just looking a little bit at the larger picture, when we think of perinatal mental health, it used to be that pregnancy was thought of as like, oh, this is going to be such a wonderful time, and oh my goodness, like, welcome to the fold, you're going to be overjoyed, it's going to be exciting. Well, we now know that mental health disorders happen in pregnancy. Pregnancy is not protective. It's not a wonderful time for a lot of people. It's a time of stress, and stress, whether good or bad, can precipitate a mental health illness. In pregnancy, in my job, nothing is more important than maternal euthymia. So we, as a society, have a stigma against mental health. We, as a society, have a stigma against medication use in pregnancy. It's not natural. It could be harmful to the baby, despite extensive data now collected over decades. So I work constantly against that stigma to say, listen, if you can't be a healthy mom, it's going to be hard to have a healthy baby. It's going to be hard to have a healthy parent. Depression during pregnancy is the strongest predictor of postpartum depression. So the earlier we can catch it, the better off we are in the long term. The most robust predictor of postpartum suicide is a history of psychiatric illness. The risk of suicide is 70 times higher in women with psychiatric disorders during the first year after childbirth compared to the general female population. 70 times higher. So if that isn't a little bit of an eye-opening statistic about how we need to pay attention to these women, I don't know that there is a better one, except maybe below, which we already talked about, that suicide and overdose combined are the leading cause of mortality for women in the first year following childbirth. So when they looked at pregnancy-related suicide deaths, they noted, this is going back to the MMRCs, 62% occurred in the postpartum period. So that's suicide deaths. 62% were between 43 and 365 days, 24% were during the pregnancy and 14% were in the first 2 weeks. So we notice that the further out you get, the more risk you have. So sort of on the pictograph, the lower left block, maternal suicide is most frequently completed between 6 to 12 months. So it's a little further out. You can imagine, once you have the baby, initially moms are often surrounded by support, or they leave the hospital and they try to be optimistic. I can do this. I'm going to step into my new role. I'll be able to do this. And as weeks and months go by and they maybe can't seem to get themselves to their appointments, family who might have been in town go home. With COVID especially, they didn't have a lot of people coming in to help. Support groups weren't meeting. That their internal resources start to drain and they become more and more despondent. I don't think there's data on that, but I think it's easy to imagine how that could happen. So what does untreated maternal stress do? It causes dysregulation of the HPA axis, elevated cortisol levels. Those can stimulate labor, so women who are depressed are at increased risk for preterm birth or birth complications. Those elevated cortisol levels pass down through the placenta. They cause a decreased birth weight in the child, potentially. And then we know, we've all seen stories, it was on the cover of Time, fetal programming a number of years back. That is responsible. So maternal stress changes the actual epigenetics within the fetus, which then predisposes a child to longer-term health complications. It's sort of adverse fetal experiences almost, right? We know about adverse childhood experiences. We're talking about things that happen even before the child is born that lead to an increased reactivity to stress, an increased vulnerability to mental health disorders, and an increased vulnerability to diabetes, asthma, hypertension, cardiovascular disease in the long term. It's fairly stunning. I'm stunned. So untreated depression and stress during pregnancy is increasingly appreciated as a toxic exposure. So when patients say to me, like, I don't want to take medication, it's not good for the baby, I try to take a deep breath and I say, listen, what you're experiencing now isn't okay for the baby. That is causing changes that might not be seen for 20 years. As crazy as that sounds, we have data about it. It's not real. The infant is at risk for impaired social interaction, delays in language, cognitive and social and emotional development. I pulled this out of PEDS article. Maternal depression in infancy is also predictive of cortisol levels in preschoolers. These changes in levels are linked with anxiety, social wariness, and withdrawal. As they age, children of mothers who are treated for postpartum depression often have poor self-control, poor peer relationships, school problems, and aggression. It's not pretty. And it also isn't cheap. Not that this should be the focus of everything, but it does give us a reason, right? This is why CMS acts. This is why changes in billing occur. This is how we build in more community involvement, by knowing that the cost of perinatal mood and anxiety disorders is high. So it's perinatal depression, one of the most common adverse childhood experiences. It's associated with the costliest adverse adult outcomes. Cost to U.S. employers for just postpartum depression, not the others, we'll get to those, are about $44 billion a year and $12.4 billion in healthcare costs. That's enough to move the needle on billing for us. We also know that, just like I said, partners can also suffer from postpartum depression, even as high as 50% when the mother has postpartum depression, which compounds the effect on the children, creating an adverse childhood experience. We can't go any further. Let's see. We're stuck. We're going. So what does it mean? What are the sequelae of perinatal mood and anxiety disorders in the postpartum period for the parent-infant dyad? Right? We think of them as this intense building bond. A child, I'm sure I'm speaking to the choir about this, but builds a sense of security, attachment, an ability to build relationships as part of that initial bond with their primary parent. When you have a depressed mother, I don't know how many of you have close contact with one, probably a lot of you, they don't want to touch their baby. Or they want to touch the baby less. They know they should, they know it's important, they don't want to. Pulling the desire out of what now becomes a chore is pretty profound. And if you think that doesn't translate to the child, right, you're kidding yourself. So we have impaired bonding and attachment. I was really struck, I read this many years ago, but that I work a lot in addiction, and women with addiction fall under the gun a lot, right? DSS loves nothing more than a mother with a substance use issue. Like, we gotta rush in and say that. How often do you hear that DSS is rushing in for a mother with depression? Like, never. But the impact is very, very similar. A mother with depression has trouble interacting. They read the cues of their baby incorrectly. A baby might cry, and a mother who's depressed will think to themselves, I know, I get it. Life's terrible. I hear you. I'm glad we share this despondency. That can be the mental track, as opposed to, oh, the baby's hungry. Oh, the baby needs attention. Oh, the baby needs their diaper change, right? That cue is read entirely differently through a lens of depression. Same as it is in substance use disorder, but the stigma of substance use disorder, I think, is just that much greater. And not that, all don't need intervention, although I'm not a big fan of DSS, I'll just put that out there. I just think that the skew towards substances sort of ignores what happens in PMADS. Moms have impaired attention and judgment for health and safety. They have been shown to fail to put into action injury prevention components, right? They don't prep their homes. They don't cover the plugs. The car seats aren't installed or installed incorrectly, and they're not double checked. They aren't as well versed, or they don't care, or it's not don't care, right? It's a disease illness. I want to strike that from the record. They sort of can't be bothered. The disease of depression is so great that the energy it would take to remember to put your baby on its back every time you put it in the crib feels so overwhelming and burdensome that they can't rise to that. Just getting the baby to the crib was like the part of the day that worked. So you're seeing that safety becomes compromised. They have difficulty managing chronic health conditions. If you have a preterm baby that has a number of issues and needs to come to the doctor frequently, and a depressed mom, that's pretty hard to do. Add in, you don't have a lot of financial resources. Maybe you lack transportation, having to call Medicaid to get that transportation set up so you can get to your appointment, to then get to the pharmacy, to find the money to pay for the thing, to then get home, to set up the nebulizer, right? It's a lot. It's a lot for someone who's fully functioning. I think it's a lot to take care of 2 dogs. That didn't get the rise that I wanted. And we watch them overuse healthcare and emergency facilities. So they go to the hospital more often. They use the ED more often, right? Because they're uncertain. And everything is fraught with confusion and negative self-talk, and do you even know this? Can you even help this? Should you even do that? Right? Can you imagine how tiresome that is to have a brand new baby when that is going through your mind? If you like an infographic, this is the Maternal Mental Health Leadership Alliance. I like the part on the right, this little bit right here. Untreated mental health issues in the home may result in an adverse childhood experience, which can impact the long-term health of a child. Depressed moms seek relief. Depressed moms with little financial resources, lack of support, find relief often in substance use. It is cheap and easy nowadays. That creates a cascade of events that leads to problematic issues in the children who are growing up in these homes. So what does the AAP recommend? You probably know this. Screening, validated screening tool, and 1, 2, 4, and 6 month well child visits. Every single major entity in the United States and beyond thinks we should screen. ACOG, so that's OBGYN, APA, American Psychiatric Association, the WHO, World Health Organization, United States Preventative Services Task Force, and CMS, the people who help pay for most of what we do, recommend postpartum depression screening, or PMADS, right? There's where postpartum depression gets all the press. Components of documentation in an infant's chart should include the type of screening tool you use. Do you guys use the Edinburgh? Yay! So the EPDS, the results, what you said in a discussion, and a follow-up and referral plan. So it's pretty brief. There are EPDSs in multiple languages as part of the SYHC, SWYC, who knows, I just make up letters. Or you can also, validated screening tool is the PHQ 2 and 9, but I'm glad you guys use the Edinburgh because OB uses the Edinburgh and I use the Edinburgh, so that kind of puts us on the same track. Billing is appropriate at the infant's visit because postpartum depression screens are a measure of risk in the infant's environment. Do you guys bill for that?
Yes.
We're
getting there?
Yes.
We're getting there?
Yes.
Yeah, we're looking for consistency.
Yeah, I hear that. I don't bill for it, and I suppose I could, and I don't. But you can. And I think that can enhance doing it, right? Sometimes even I am motivated by financial reward. So some tips for screening. So I sort of normalize why I'm asking about mental health symptoms. Like I make it part of everything. Of course I do. Everything I do every day, that is what I do. But for you guys, that you're gonna ask every woman, every time, about what's going on at home. How you feel? What's going on? Hey, what's up? Right? Whatever your style is. And I want you to use your team. I don't know if you guys, use iPads, have iPads in your offices. Like that's something easy. You can have the EPDS loaded in the waiting room and hand it to every person as they come in, and they just fill it out on the iPad and it gets loaded to Epic. The loaded to Epic is a tougher thing. But if you even had the score, right, you could load the score into Epic. That would be pretty easy. But there are ways, or can a nurse do it? Can she issue the depression screen so that you can just take the results and move from there as a physician or an allied health professional, whomever is doing it? You need to use, I think, interpreters. I don't know if you guys have access to the language line or you bring interpreters into your office. I just had this happen yesterday. I had a woman come in and our interpreter left and they're like, well, you can use the language line. And I was like, well, no, I cannot. Like, I'm sorry, but depression and suicide are not going to go well via a phone line with someone who isn't well versed in this language. There are several language of psychiatry, I mean by that. I'm sure they know their own language very well. But the words and the terminology that we use in psychiatry, we have two interpreters that I use all the time that are fantastic, Margarita and Sylvia. I don't know, mostly for Spanish-speaking women. It matters. Having someone there who understands the language you're using, and I know you guys don't have a lot of time for this, so I know I'm asking a lot, but I'm just going to put it out there as like my grand wish list. I encourage discussion. Like the more you talk about it, the more it's part of everything you do, the more it naturally comes up appointment to appointment, right? If you know stuff about what's going on at home, what happened with their husband, what's going on with their partner, did they go through the custody suit, right? All of that can be part of your maternal health discussion. And you can also collaborate with adult providers, right? So if they're seeing a family practice physician, you can reach out to them. Hey, I noticed this. Reach out to an OBGYN. I love when you guys reach out to me. Vidya reached out to me. And I was like, yay, like the system's working. I understand we're all really busy, but these are important things to catch. So let's look at the basics. You guys probably already know a lot of this, so I won't get too hung up on it. Perinatal mood and anxiety disorders includes perinatal and postpartum depression and anxiety, postpartum panic disorder, perinatal OCD, postpartum PTSD, perinatal bipolar disorder, and postpartum psychosis. I don't expect you to know all about it. It is not your job to diagnose it. What I want you to notice are small, worrisome factors in your patients that say to you, I think this needs to go to somebody else. I think this rises to the level where another provider, someone who's more experienced in this, can help out. So that can be an OBGYN, it can be family practice, it can be me. That's how it's broken down, just so you can see it. We think postpartum blues, 80% of people get them, right? Early onset, goes away in the first 2 weeks, not clinically significant. So you watch the SPCA commercial, Sarah McLachlan comes on, you cry more than you usually would, because let's face it, we all cry. Commercial comes on, but in postpartum blues, you're like, oh my God. Someone gives you a card, congratulations on your baby, thank you so much, right? That's working through the hormonal components of your delivery, perfectly fine. If it continues longer, or is the interesting part when we look at postpartum psychosis, you can see it's the smallest little bubble right there. And around it is bipolar disorder. So I will bring to your attention, just bipolar women are at increased risk for PMADS. They are women, if you know you have a bipolar woman who's pregnant or parenting, you want to ensure that she has adequate follow-up. I will advocate that she sees a psychiatrist. It is probably not good that she follows up with primary care. Most primary care do not have the ability to manage bipolar disorder in pregnancy. Very few OBGYNs, if any, do. It's something that needs to be seen by a psychiatrist, and largely someone like me who deals with a lot of mental health issues during pregnancy and postpartum. But back to the blues, big circle, and then lesser, but you can see standing right next to postpartum depression is anxiety disorders, smaller percentage bipolar, and smaller percentage postpartum psychosis. Postpartum psychosis is quite rare, 1 to 2 in 1,000 women. It is the only emergency in perinatal mood and anxiety disorders that we recognize. If someone is not in touch with reality, and unfortunately it tends to be quite rapid, so it's in maybe the first week. It can go outwards to 6 weeks, but in that first week after delivery, someone is separating themselves from reality. They become delusional. Excessive worry about the safety of the baby. Someone's coming in. They may have hallucinations, see the baby covered in blood. That would be not abnormal at all. And it is hard to hear, and most mothers early on know that they should never say that, right? Because that's not good. So they don't like to talk about it. But if you ever hear, sometimes the actual mother will not know that it's happening. It's the partner that notices. She's been doing some strange things. She looks around the door. I hear her talking to somebody when the baby's asleep. I hear her checking cabinets, washing hands, things that are outside the norm for a patient that might awaken in you like, oh, that doesn't sound good. Generally speaking, I want them to go to the ED without passing go. If a parent or partner can take them, put them in the car, drive them, great. If not, call 911. These are the people that we read about in the news who kill their children and kill themselves. It doesn't happen very often, but when it does, obviously, tremendous tragedy. So who's at risk for a PMAD? Mother and father, if they're minor. Personal or family history of depression, anxiety, and I blued out the bipolar disorder just to give the heads up towards postpartum psychosis. Also, people with eating disorders, OCD or substance use disorder, SUD. History of ACEs. Previous PMAD in a prior pregnancy or postpartum. A history of sensitivity to hormonal shifts. You guys might not ask this, but I know a lot about it. People who have a lot of problems with their periods, menstrual dysphoric disorder, might take medication simply because of the mood fluctuations around their period, they're at increased risk. Because think pregnancy, huge time of hormonal shifts. Unmarried or marital conflict, poor marital satisfaction. If you have someone who has a thyroid disorder, because we know in pregnancy it's oftentimes going to be unsteadied. Poor social, familial, financial well-being, no health care, lack of access to health care, or lack of transportation, so increased barriers to care. Additional factors, sort of abrupt medication discontinuation. We'll get back to this, but if someone's on an antidepressant, don't stop it. Please don't stop it. Don't tell your women to stop their medications. Tell them to call their doctor or reach out to me. You shouldn't stop your medications except possibly one. Does anybody know what one medication I would tell a pregnant woman to stop if I knew she was taking it? The most teratogenic. Depakote, valproic acid or valproate. Yes. We know that that has defined teratogenicity. It matters your exposure over the course of the pregnancy, so the sooner you stop, the better off you are. Most women don't know they're pregnant by the time the damage is done, but if you do and you can stop it, then that might be the only one. If someone has tremendously terrible bipolar disorder and that's the only thing they found that worked for them, that might be a small caveat, but you would not want to take that risk. Probably I'm the only one who would want to take that risk, and I will tell you, I have never taken that risk. I have been able to find alternative medications every time out. So a recent loss or an unresolved loss, and that the pregnancy is unplanned or an ambivalence about the pregnancy are additional exacerbating factors. I think we can all remember symptoms of PMADS, right? SIGE caps from when we were in medical school. We'll drive it up again, but this is a very helpful infographic from Postpartum Support International, so people can look for that. There again is an infographic about baby blues versus postpartum depression. The thing to sort of think about is that postpartum depression is usually onset later, more severe and clinically impactful, and it can occur up to a year after birth. And there it is, the stigma against medication use during pregnancy is dangerous. Coming off meds to have a natural pregnancy poses potentially life-threatening risk to both a woman and her pregnancy. And I hope I sort of made that clear. What does choosing treatment look like? We talk before they get pregnant, particularly bipolar women, women with a long history of mental health issues. How can we best prepare? Let's get you feeling as best as you possibly can going into a pregnancy. We know that greater than 50% of pregnancies are unplanned, so that doesn't always happen. But that's the best case scenario. When someone is pregnant and going to take medications, we obviously limit the number. If we can get away with one, we want to get away with one. If we can get away with one at half the dose and it's still impactful for the patient, then let's do that. We're going to use a medication with a known safety profile that is favorable, which is a lot of medications these days. And we're going to add on non-pharmacologic modalities like peer support, group therapy, meditation, mindfulness, church, sleep, diet, exercise. Like, let's throw the whole kitchen sink. Is it going to hurt anybody? Probably not. Treatment guidelines, this is for me, but just so you know, if I get a mild to moderate EPDS, so I sometimes like to say 10. I put 9 to 12 because that's sort of like the textbook. But like 10 is your marker. Above 10, we're sort of at risk. Above 20, we're frankly in the PMADS zone. Between 10 and 20, we don't know. What would I do? If you're around 10, I'd probably try lifestyle changes, all the things I just mentioned. Do you want to see a therapist? Pretty much everybody benefits from a little CBT, mindfulness-based stress reduction, anything that you're willing to engage in, I'm sort of willing to set you up with. I love CHIPS, I love healthy families, I love Now Feed, Read, and Grow. Like, if I can get you involved where you have contact with other people going through a similar thing, let's do that. As we get higher, 10, 12, 15 and above, we need to move into medication. And if you're seeing people, I want you to encourage them that it's generally safe and there are people who are knowledgeable and use it appropriately. So what are our guidelines We don't stop all medication. Most are safe. I think I've driven that home. I won't say it again. Well, I probably will, but I'm going to try not to. If your patient has a history of mental illness, perinatal or otherwise, encourage them to speak to a mental health provider. So that's someone who has expertise in perinatal mental health. There aren't a lot of us, but there are some. And maybe in each department we can find a champion, someone who knows a little more than the rest, so each of us could feel more comfortable reaching out to them to get answers. I want you to use all your resources. Every mother can benefit from support and therapy if they're willing to go. I don't want to, cattle prod people into doing things, but if they're open to it, you might find out that they love it. Remember that exposure to psychiatric illness counts as an exposure to the child. How do you get someone to me? What if you find someone that you're like, oh, I remember I was in that grand round and she said she should probably get someone to me. We don't have a great process. It is very hard because you treat the child and I treat the mother. You are allowed to have access to the maternal chart to message me. That is because you're doing screening and surveillance for the infant. That impacts the mother. I don't care how you send it to me. So like Vidya and I, she was trying to get someone to me. I think you used all the methods, which is great, but you can call me. I didn't put my number down here because sometimes that's a little scary to put. I'll just admit that. Handing people my cell phone number, I wasn't quite there yet. But you can. It isn't hard to find, right? If you call my department and ask, you can get it. You can perfect serve me, right? We all have our phones everywhere. You can staff message me on Epic. Hey, this is what I noticed. I have a question, or I think she needs a referral, or how do I get her there? If you do feel comfortable, you can make an ambulatory referral to OBGYN, the Highland office, attention me, to get the mother to care. But it would be the mother's chart, and I understand you don't have ready access to that chart, so I put it up there just so you know how to do it, but you don't have to. I tried to take a screenshot of it, but it was ridiculously, yeah, it looked retarded, so it looked moronic, sorry. Okay.
The next upgrade.
Right. That's what we need. So some lessons I've learned, like words matter, how we talk about mental health matters. You have to sort of, if the more everyday it becomes with you, the more easy language you use, the better off patients are going to feel talking about it. I'm sure you don't never underestimate the power of trauma. Trauma impacts every part of a woman's life, and upwards of 70% of women now, and certainly higher for lower socioeconomic classes, have a history of some form of trauma. Pregnancy is a really incentivizing time. Moms really want to do well for their new babies and their children, so we can use that to help them get to care. Postpartum support is imperative. So like I said, I try to throw the kitchen sink at them. And I don't give up before the miracle happens. If someone's like, I don't want to do this, I'm like, all right. How about I just keep talking to you? You want to come back next time? Like, here, I'll just put it in your after visit summary. Here's some stuff in your after visit summary. I love the after visit summary. Just like 27 phone numbers, that's all right. You need one? Use one. You like talking to a therapist? I put down 20. Just find one, it's all right. Right, I just, is it going to hurt? No, I do it every single time. Hey, have you heard of CHIPS? Have you heard of Health Fit? Dr. Wells, you told me about that last time. Let me tell you about it again. I just try to keep it light and meet where they are. And if someone's like, absolutely no medications, I'm like, I 100% respect that. Let's talk about other things we could do. How else can I help? Why don't you keep coming back? Because I think sometimes offloading what you're feeling can be helpful. So what's going on here? Did you know there are 2 psychiatrists with perinatal training who see patients in the OBGYN clinic weekly? That's myself and Dr. Carrie Stevenson. So we do have a place for these women in OBGYN clinics, so where they go to get their regular OBGYN care. We have a website. You can look it up. It's not that magnificent. It's really nothing great to look at, but we're working on it. Carilion's fussy about what you can put up there. There is aren't they? Yes. I get it. They're a big health institution, and I just want to go off and do what I want to do. You're not allowed to. There is a women's mental health collaborative that meets the first Friday of every month. It is a joint collaboration of OBGYN, pediatrics, psychiatry, family and community medicine. There are social workers, allied healthcare professionals, psychologists, every type of person that wants to be involved in promoting women's health through education, improved access, and interdepartmental collaboration. We meet. If anybody wants to be on the list, just send me my chart or an Epic staff message. I will happily add you. Me and Vidya hang out there. Psychiatry and OBGYN already, me and Dr. Nunziato, Jackie Nunziato, work closely on building something called the Embrace Project to improve PMADS screening and treatment at Carilion Clinic. We're involved in submitting a HRSA grant right now, hoping to expand perinatal mental health access throughout the state of Virginia over 5 years. Coming through the tunnel right now are RAC cards and referral sheets that I had hoped to be here today but are not. But just have a couple of phone numbers for moms in case of emergency or in need of consultation that you could just put on your refrigerator, and a referral sheet to use that has resources and how to do a referral should you choose to. We do have, I've been working on a perinatal ED fast track, so that's pregnant and parenting women with perinatal mood and anxiety disorders get fast-tracked out of the ED and into a bed or home or quickly, because can you imagine having just delivered an infant and sitting in the ER for 13 hours and no one sees you and your baby's hungry and you're leaking milk and it's tremendously uncomfortable, and that probably isn't good for the woman with depression and anxiety. We're working on a perinatal consult service, so that's a psychiatrist who would see all postpartum women who screen positive after delivery, anybody who had increased risk, and anybody on the antepartum service as well. I would love to see that, and we've talked about, we first have to get it up and running, but I'd love to see that expanded into some programming on the unit that extends into moms who have babies in the NICU, so that they could come to a support group and learn about perinatal mood and anxiety disorders, or how do we reach out for help, or what does breastfeeding look like, or any number of topics that would be helpful, supportive, and diminishing the impact of having a preemie infant. And then we're working, as I said, on a grant that is designed to build out the perinatal consult line, and Sandy Chung, who does Virginia Mental Health Access, we're sort of talking with her and trying together to move on from adolescent and child psychiatry consultation line to a full maternal mental health consult line. And that's, that's what our Embrace project looks like. That's how we're working. Yeah, it's really easy, just simple, just follow the blocks. But that's about how we teach providers to feel more comfortable treating basic mental health conditions in pregnant and parenting women, because I can't do it all. I need everybody to join in beginning to use Zoloft, Celexa, Lexapro, Wellbutrin, like working on getting our other providers comfortable doing that so that only the most serious come to me. I did want to provide you with a bunch of resources that I use so that you have them. They're at the end of the slides. For learning about the pharmacotherapy that I use, MGH, or the womensmentalhealth.org, has a vast amount of information. For patients and providers, the simplest one is mothertobaby.org. It will provide you with printable infographics on any medicine you put in. So if a mom comes to you and says, like, well, what about Zoloft? You can just go to mothertobaby.org, type in Zoloft, get a little sheet, print it out, hand it to her. It's in very readable style. It makes sense. It's simple. It has all the information you need. Like, this is the effect in pregnancy. This is the effect on breastfeeding. This is the effect long term. These are the things we know. It's very good. And you guys probably don't use it a lot, because why would you? I put on some other ones in case people are interested. There is a Postpartum Support International Perinatal Psychiatric Consult Service, but It is obviously doing the job for the entire country that, like Virginia Mental Health Access just does for Virginia. So you can't get immediate access, but if you had a pressing question, it's probably a good place to go. Here are some resources for patients, and this is part of what's on the RAC card, the 988. If you have an emergency, we use 988. If you need rapid help, non-emergent, I say call the Help for Moms line, National Maternal Mental Health Hotline through HRSA, 24/7 free and confidential hotline. And then I also like the 1-800-944-4773 Postpartum Support International Helpline. Do any of you use the Erickson Institute Fussy Baby Network? I've not tested it. I have called them. I've called every one of these to see what would happen. They do answer, they do respond, you can call with your fussy baby to these people and they will help you. It's 9 to 5 Central Time because they're based in Chicago. But that's pretty awesome. You have a colicky baby, you're running out of steam, call for some support. These are sort of resources if you want to learn more about PMADS. Here's a short list that I put. If anybody wants to read about stuff in my area, here are some sort of more readable things. And thank you so much for your attention. I really appreciate it. Any questions? There's a bunch of references if you need them.
There's a question in the chat.
Question in the chat.
Dr. Kreider, first she said, amazing talk. I love the way that you described the energy effect of depression as an inability and not lack of desire. And then her question, do patients need to be established Carilion OBGYN patients in order to be referred to you or Dr. Stevenson?
No. Is it sort of harder? Like the Lewis Gale midwives have my number, so they text me directly if they need something. What I need to know generally is name, date of birth, insurance. I need those things. And an accurate phone number. Sorry, gotta have a phone number so that I can reach back out. You can get it to me, I can get it to my scheduler can call them. It would be helpful if I had a little bit of a snapshot of what they had. And I want to sort of emphasize that if it's sort of minor depression, I want you to try to reach out to the OBGYN. I don't want the quick response to be like, oh, I know Dr. Wells, I'm going to send it to her, right? Like I do get a lot of referrals and I appreciate that and want that, but most need Zoloft. And I want to impress upon our other departments, like that's something you're going to need to handle. This crisis is so big, I need you to handle it. We can't do that. But can I consult? Absolutely. Can I send a MyChart back? For sure.
I had a question. Why do we stop screening at 6 months when the incidence is highest at 6 to 12 months? And as someone who sees a lot of these moms that score somewhere between 5 and 9 sort of consistently, what's my trigger to continue screening?
I think if you're at 5 and 9, you should continue screening. Like, why would you stop? Because now you know that the data tells us, right, that the incidence of mental health disorders is getting worse, particularly if you have an at-risk individual. You have a sexual and gender minority, you have a BIPOC woman, you have someone who has limited financial resources, you have like a single mother who doesn't have a lot of support, right? Like you know the chances that it can get worse are high. I continue screening. I do not know why it stopped at 6 months. Do you know? I don't know.
It's just completely counterintuitive when you see that data.
Okay.
And I was like, well, wait, I've like been like, good, 6 months and done. And now I'm like, oh my gosh, I never tracked those people that have been scoring something to say, I need to check in on you again and again.
And that's why I sometimes think, like screening's wonderful, and we need it because that helps us hold to a line. We put it on our checklist. We know to do it. But if you're developing a personal relationship, which I know you all do with your patients, I think you're able to say like, hey, it sounds like things have been worsening. How have you been coping with that? What can I do? What do you need? Have you ever thought that you have depression? I can't tell you the number of mothers that have their second child reflect back on the first and are like, oh my God, I was so depressed and I didn't even know. These are physicians, these are professionals, because the stigma's so great and I'm gonna do this, I'm gonna power through.
Is there a code, an ICD-10 code for at-risk birth?
I'd have
Because
to
it
look.
feels like if we could bring that through, like the OBGYN recognizes it, it comes from the nursery, that we're not gonna miss, you know, maybe the mom's not gonna tell us, oh, I'm bipolar because of stigma. But if that could come through, then that's gonna help in tracking, and I'm not aware of
Oh,
that
shit,
code.
I don't
myself.
either, but it's a great idea.
That's the hot topic of how to get the warm handoff of
Yes.
those at higher risk. And I think, you know, it sounds like you guys have your, I don't know what the title of your task force is, but you know, oversight group, whatever, but hopefully, and hopefully video, I don't know if you have other representatives for peds on there. Good.
Olivia's on it.
Olivia?
Excellent. I thought
Amanda-
oh,
Amanda.
excellent. But I think the idea that the screen and the repetitive was good, because we also know that the earlier you treat, but that your patient, well, I don't want to say your patient risk, we have a patient population that's certainly higher risk that may not come in at 1, 2, 4, 6 months, right? They may
That's
come
the
in
thing, like,
1 month at 7 months.
if you're so depressed, you miss. That's what I was thinking when you said, why do we stop at 6? We're like, why, what if you only make it to the 9 months? And it might trigger into you, like if you have a baby that's behind on immunizations, why are we behind? Like what happened?
It sounds like an interesting project too, perhaps.
It does,
expanding to
quality
9
improvement
months
or
and
something?
Follow what kind of results you get, I don't know.
I put it on my problem list. Neonate at
Neonate
risk
affected
by maternal mental health. And so I just tag myself, put it on the problem list so I'm remembering. And so
There is
many
a
times.
There's a diagnostic
There's a
for
diagnostic
it,
code,
yeah.
and so many
I'm also
times,
thinking that, so,
it's
yeah,
the same patients.
the at-risk
that
patients
miss
are not
appointments.
necessarily going to be seeing you consistently.
And,
They-
yeah.
they may
yeah.
be seeing a resident one time, they may be seeing, you know, and they may not.
Yeah,
even
and then
see
so no one has the long-term,
Right.
I also routinely enter mom's chart. Like I always ask in the initial visit, do you mind if I take a look in your chart to track things going on in pregnancy to make sure everything was done and the labs are okay? Just to check the baby's health. Is that not allowed?
no, it's totally allowed.
It's allowed, but many of us don't just because of the high risk for a HIPAA violation. I would have, if I was doing that, I would actually have mom sign something and make sure it makes it into the chart, rather than you just saying you alone had verbal permission to go in.
Gotcha, okay.
But many times in the newborn history from the nursery, they will have at least one tiny line.
In
Mom
the
has
first comment,
depression,
yeah.
anxiety, whatever, and I always clip that and put it in our notes, which comes into every note. So I'm at least triggered, okay, there's a higher risk of postpartum because I know she's got. Because many times when we ask the family history, you don't get that history. Diabetes and the asthma and the high blood pressure, but they don't say
Depression,
the depression,
yeah,
anxiety I had struggled with, unless you specifically ask those questions. But maybe
And that
I
would
need
be a
to
great
asking
screening
better.
tool for the first postpartum visit, right? Is do you or your partner have history of these mental health
Exactly what I was
disorders?
thinking. Like, we need to ask maybe more specifically.
Well, I super appreciate you guys being here. It was nice to be in person. It's the first time in several years.
Thank you for coming. Those that were online and didn't join us in person missed a wonderfully dynamic individual and a dynamic talk, and thank you for coming out.
Sure.